Hi, everyone. Good morning and good afternoon to many of you. Thank you so much for making us part of your day. My name is Carolyn Chu. I'm the Clinical Director of the National Clinician Consultation Center. I'll just be doing a couple of short intros and then we'll get it over to our speaker, Dr. Padia Saberi. First, I just wanted to welcome our partners at the Bureau of Primary Healthcare. Jane Baru will be saying a few words of introduction, so let me just go ahead and turn it over to her without any further ado. Jane is a public health analyst within the Bureau of Primary Health Care's Office of Quality Improvement at HRSA.
Great, thank you. Good afternoon, everyone, and thank you for joining us this afternoon. I am Jane Baruby, a public health analyst within the Office of Quality Improvement within the Bureau of Primary Health Care here at Health Resources and Services Administration, or commonly referred to as HRSA. We are grateful to have the National Clinical Consultation Center prepare this webinar today on such an important topic. The Bureau is committed to leveraging our strategic partners in delivering the latest information and promising practices and supporting the work performed at our over 1,400 health centers. Before I turn it back over to our presenters, I'd like to share some information about our health center program at HRSA and some of the initiatives that we are working on related to behavioral health and HIV prevention. Next slide, please. Sorry, am I getting the slides? Can we advance to the next slide? Great, thank you. According to our 2018 Uniform Data System, HRSA-funded health centers served more than 28 million people across the United States. That's 1 in 12 people, 1 in 9 children, 1 in 5 rural residents, and 1 in 3 living in poverty. Health centers provide affordable, comprehensive, quality, patient-centered care through a range of services. Our mission is rooted in increasing access for vulnerable and underserved populations, and includes providing services to more than 385 veterans. More than 800,000 are served at our school-based health centers, nearly 1 million agricultural workers, and more than 1.4 million homeless. Next slide, please. HIV prevention is the focus of HRSA health centers. Our goal is a 75% reduction in new HIV infections by 2025 and at least a 90% reduction by 2030. We have several focus areas for prevention, including outreach, increasing outreach to new and existing patients to identify those at risk for HIV, HIV testing, increasing the number of new and or existing patients tested for HIV, PrEP prescriptions, supporting the implementation of clinically indicated PrEP, linkage to care and treatment, linking persons who test HIV positive to care and treatment, partnerships, so bolstering and establishing new and or enhancing existing partnerships to support identification of at-risk individuals, and personal impact, so increasing the personnel who will support the expansion of HIV risk reduction, access to and use of PrEP, and linkage to HIV care. And if I could just point out some of the resources that we have at the bottom of this slide here, if you all get a chance at your convenience to check out some of our links to some of the TA that we provide around HIV, that would be great. Next slide. Great. During fiscal years 2016 to 2019, HRSA invested $545 million to increase substance use disorder and mental health services at our health centers. According to our 2018 UDS data, more than 95% of our health centers are providing mental health services and are providing substance use disorder services to more than 223,000 patients. Health centers are encouraged to implement evidence-based practices, including screening, brief intervention, and referral to treatment. Our 2018 UDS data shows approximately 1,099,000 patients received SBIRT services in 2018, an increase of over 50% from our 2016 data of 716,677 patients. We've also seen a significant increase in the number of patients receiving medication-assisted treatment, or MAT services, which combine behavioral therapy and medications to treat substance use disorder. In 2016, health centers were providing these services to approximately 39,000 patients, and in 2018, this number has more than doubled to over 94,500 patients. Telehealth is also a promising area of focus to address substance use disorder. We recently added telehealth to our UDS measures, which indicates that more than 20% of our health centers were using this technology to address substance use disorders in 2018. And we'll be interested to see how those numbers change in 2019. And again, we provide below here a list of our technical assistance resources and encourage you all to access those when you all have time. And so with that, I thank you for listening, and I'll hand it back over to our presenters.
Great, thank you, Jane. Actually, Padia, I might just ask you quickly, we are getting a message in the chat box, thanks Brian, that I think everyone's seeing the presenter view. Can you change the display settings so that the content on your slides shows up a little bit more easily? Okay, all right. While Dr. Saberi is doing that, let me just go ahead and present her. I'm really pleased that she has agreed to speak for our group, because I think there are very few people who I know that know PrEP as well as Padia does. So Dr. Padia Saberi, she is an associate professor of medicine at UCSF Center for AIDS Prevention Studies, and she's an HIV clinical pharmacist by training. She's funded by the National Institutes of Health as well as the California HIV/AIDS Research Program, and her current areas of research include remotely conducted research, adapting technology-based strategies to challenge current models of healthcare, and improving HIV prevention and treatment strategies through social networking technology and web-based tools. She is principal investigator of an NIH-funded project to improve HIV PrEP prescribing practices through technology-guided panel management strategies in primary care clinics across the San Francisco Department of Health, and you'll be hearing a little bit more details around her work later on in her presentation. Thanks very much, Padia.
Hi, everyone. Thank you so much. I don't know what the blue line is. I apologize for that. Thank you so much for having me present today. I really appreciate it. I want to give a shout out to all of my colleagues at the National Clinicians Consultation Center and my colleagues at UCSF at the Center for AIDS Prevention Studies. So today we have a lot to cover. First, we're going to be talking a little bit about national trends around HIV pre-exposure prophylaxis for populations at risk. Briefly talking about new PrEP medications and dosing strategies, and really discussing some unique considerations for people who use substances. And then finally, I want to leave you with some efforts that are being currently conducted via various research projects and interventions across the US for educating, initiating, and persistence of PrEP. And I use a ton of acronyms, as this is my entire acronym list. I wanted to have this here in case you ever need to go back to this list. I have an acronym problem. So it's all here if you have any questions about what we're discussing. So I wanted to start out with talking about some of the encouraging trends that we've seen in San Francisco. Just to orient you, the orange bars are the number of living HIV cases. The yellow line trending downwards is the number of new cases, and the blue is the number of deaths. And as you can see here from the yellow line, since 2012 to 2017, we've decrease the number of HIV, new HIV cases by about 50%, over 50% actually. And these are really encouraging trends and really goes to show the great benefits that treatment as prevention and HIV pre-exposure prophylaxis have had within the city of San Francisco. But it also is a reminder that we need to do a lot more. And if you look at some of the national trends, you don't see this, lovely decreasing line. And instead, there's kind of a flatlining of a number of new cases. And again, just goes to show that we need to be doing a lot more and engaging people in pre-exposure prophylaxis and prevention in general. So PrEP uptake in the US has gone up quite a bit. So 870% increase in PrEP starts from 2013 to 2016. I'm sure it's gone up a lot more in the years past 2016. But what we do know from 2018 data is that that there's an estimated 1.2 million people who are eligible for receiving PrEP, and only 18% are receiving it. This is a map from AIDSview, and if you haven't had a chance to look at their website, I highly recommend it, especially if you're a data nerd. It really captures a number of new infections, HIV incidence, prevalence, and then also this really interesting concept of PrEP to need ratio, which is basically the ratio of number of PrEP users in 2018 over the number of newly diagnosed individuals with HIV in 2017. So it's really kind of a surrogate for how many PrEP use, how PrEP use compares to the need. So the lighter the color is, basically it means that there's fewer PrEP users relative to the need, and the darker it is means that there's higher users. So as you can see, the vast majority of the US is white, basically, and doesn't have white color, and doesn't have the PrEP to need ratio is quite low. And with just about everything medical, there's a lot of disparities even with PrEP use. And in general, the annual PrEP to need ratio, even though it's increased from 0.3 in 2012 to 4.9 in 2014, which basically means that in 2018, for every one person who was newly diagnosed with HIV, there were 4.9 HIV negative individuals on PrEP. So we've had this great increase, but there's a lot of disparities, for example, along sex, gender, and race ethnicity. So for example, as you can see in the bar graph on the right, that there's very few female PrEP users on the far right. And then in the middle, if you look at the comparison of race ethnicity among male PrEP users, individuals who were African American and Latino have a much smaller use of PrEP. We also have disparities with regard to age. So for example, those who are less than 24 years old, which in the bar graph in the bottom is in red, so 12 to 24, across all the years from 2012 to 2017 have had less use versus those who were 25 and older. And what we do know from the number of newly infected individuals that among this younger group, there's a higher number of individuals who are newly infected. As far as region as well, so southern US, for example, there's fewer, as you remember from the graph, the map I showed you of the US, there's less PrEP use in southern US. Similarly, when it comes to education, so fewer years of education is associated with or has been linked to lower PrEP use. Additionally, for risk factors, so as we know, people who inject drugs and those who report heterosexual sex as their primary risk have lower PrEP use in comparison to men who have sex with men. There's also disparities in mortality among people who inject drugs. So I just wanted to highlight this because it was newly presented at CROI this year. So this is a study that basically looked at data from the New York City HIV surveillance registry and death from the New York City Vital Statistics Registry and National Death Index. So they looked at over 145,000 people with HIV, and of which 25,144 reported a history of injection drug use. And as you can see, mortality has decreased in all risk groups. So injection drug use, heterosexual, and men who have sex with men from 2008 through 2017. However, mortality among people who people with HIV who inject drugs remains persistently high, as you can see from the blue line at the top of the graph. There was also a systematic review of PrEP use that was recently published in JADES, and they basically looked at self-reported PrEP use and disparities among key populations. They found 95 eligible studies, including over 95,000 US-based survey respondents. And only 6.3% of these studies focused on people who inject drugs. And basically, they noted that the overall proportion of self-reported PrEP use in the more recent years, so 2015 to 2017, for the overall population was 11.3, but among people who inject drugs was 3.7%. And the number of studies that looked at people who inject drugs was so low that they weren't even able to calculate a growth rate to show whether there's an increasing or decreasing trend. So what is PrEP? So PrEP is basically a single pill, once daily pill that HIV seronegative adults and adolescents weighing greater than or equal to 35 kilograms can take to help prevent HIV. And there's two medications that are currently FDA approved. One is called Truvada, which is a combination of tenofovir disoproxil fumarate and emtricitabine. The second one is Descovy, which is tenofovir alafenamide and emtricitabine. And I sometimes go back and forth, going back between the brand and generic names, so I apologize in advance, but sometimes it's just easier to say brand names versus generic. This is one of my favorite slides because it's very colorful and pretty, but also because it's a really clear trend line showing that with increased drug levels, i.e. Truvada levels or tenofovir emtricitabine levels in blood, there is an increase in effectiveness. So these are all the major clinical trials that have been done that are listed in the colorful circles, and essentially showing that with increased drug levels, there's an increase in effectiveness. And this is really important going back to adherence principles, that unless someone puts a medication in their mouth, it's not going to work. And in addition to HIV prevention, which is, it could be as high as 90, 95% or even higher, depending on the risk, there is a lot of other impacts that PrEP has beyond HIV prevention. So some of the things that have been reported have been individuals taking control over their sexual health, improving their healthcare approach, reducing anxiety regarding HIV, increasing their sexual satisfaction and intimacy, rebooting their conversations with their healthcare providers and their community about HIV prevention. There's been several studies that have shown that patients have been connected more to primary care and insurance, so increased vaccination, increased general primary care with PrEP use, and general safety and health of the individual. So who can benefit from PrEP? I've listed here a series of general quote unquote risk groups, as well as possible risks that can put someone at increased risk of acquisition of HIV. However, I don't want to stress the actual risk, because oftentimes what is really most important is anyone who asks for PrEP really can benefit from PrEP. And it doesn't necessarily have to be, we don't have to be placing people in specific buckets and categories to have them benefit from PrEP. So pretty much anyone. And a lot of providers ask me, you know, how like it takes so long for me to figure out how many sexual partners someone has and whether they share needles and so on and so forth. And my response to that is, instead of asking all those details, maybe instead ask everyone universally that walks in the door if they're interested in hearing more about a pill that could prevent HIV. And then you can take it from there. And you don't necessarily have to get into the weeds of how many sexual partners, but really giving people the information that they need to know about HIV, and then allowing them to decide whether they fall into one of these risk categories is more important. Excuse me. So there's a lot of baseline and follow-up testing. I have listed them all here, and everyone's going to get a copy of the slides, and you'll have the list of this. I just wanted to stress a couple of things. One is that the HIV testing should be a 4th generation test, and that's what's recommended. Although with the current pandemic, there is some discussion about using 3rd generation testing, given that there's a home-based test available. The other thing I want to stress is this 3-site STI testing, and really doing only urine testing is really not enough, and we really need to be understanding what orifices people are using for sex, and deciding and ideally doing all 3, rectal, oropharyngeal, and urine for chlamydia and gonorrhea. I also wanted to really quickly discuss within our group, and I'm going to discuss our study toward the end of this presentation, but we have a PrEP initiation and persistence project that's currently ongoing within the city of San Francisco. And when the current SARS-CoV-2 pandemic occurred, as I noted in the prior slides, that we have to do a lot of testing, and we found that to be quite difficult to manage because some labs were closed and a lot of patients didn't want to go into clinics. So we had to really quickly think on our feet and come up with some internal guidance. And essentially, we came up with a few things that I thought may be interesting to share. One was that we deemed PrEP services as essential, particularly for baseline labs and also for people who had not done labs within the past 6 months. So if anyone had wanted to start PrEP and wanted to come in for testing, that was deemed essential, and we allowed for them to come in, as well as people who were already on PrEP and had not had labs within the past 6 months. Also, if anyone reported any symptoms of STI side effects or any flu-like symptoms that sometimes could resemble HIV, acute HIV or COVID-19, we also made sure we communicate that really clearly with their healthcare providers to let them decide how they wanted to handle further testing. We also came up with some internal protocols for follow-up labs. These are for people who were already on PrEP. So we basically said that if someone had been adherent to PrEP in general, and they had been coming in for labs, doing everything, as suggested, they weren't reporting any signs and symptoms of acute HIV, we would allow them to skip their quarterly labs and refill their meds for 3 months. So kind of pushing the need down the road. And also for those who had any trouble with PrEP, but didn't report any signs and symptoms of acute HIV, we did an additional 1-month refill and delayed the labs by 1 month. For those who reported any acute symptoms, again, as I said before, we would coordinate this with the provider to really understand what they wanted to do and how they wanted us to handle it. And luckily, the CDC did finally catch up. And on May 15th, we had this Dear Colleague letter. And one of the things that I thought was particularly interesting, I highly recommend looking at this letter. But one of the things that I thought was quite interesting was that they did mention the potential for using the home-based testing kits for HIV, which is currently available and which is not 4th generation. Also, there is a group in Vancouver that does dried blood spots testing, and they do, for that, they can run a 4th generation HIV test. So we've actually been in discussion with them to provide kits for our patients at San Francisco Department of Public Health to conduct HIV testing if patients don't want to come to clinic. So I also wanted to quickly discuss drug-drug interactions. This is a question that had come up a lot in the questions that the audience participants had written before the presentation. So I basically did a comparison of all the drug interactions between tenofovir alafenamide and TDF. And as you can see, with all the medications, these are most of the medications that are currently used for substance use disorders. There's really no drug interactions. The one this is a weak interaction, and really it's not problematic. The potential interaction between TDF and topiramate is that they both are eliminated by the kidneys. So it's possible that they can each cause some impact to kidney function. And really the only thing to do is just monitor, which we're already doing anyways. So prescribing PrEP, so we have TDF FTC, which is 1 tab once a day. Also similarly, we have TAF FTC, 1 tab once a day. I usually suggest writing this for 30 pills with 2 refills. One thing that has come up a lot among our patient population is the ICD-10 codes, because there's a lot of stigmatizing ICD-10 codes out there. So what we have been using and what I would recommend is Z20.6, which is contact with and suspected exposure to HIV. And really, the reason for that is that we want to really avoid stigmatizing language, and patients can nowadays see their charts through patient portals or even as the provider's documenting. So it's better to just avoid any language that's unnecessary. So PrEP adherence, this is a really important area. As I said before, you need to put the pill in your mouth before it works. Luckily for MSM, even taking doses up to 4 times a week has been associated with 96% efficacy, so that's wonderful. For women, however, and people who inject drugs, really higher adherence is necessary until we can come up with better studies to show what level of adherence is needed for other medications and dosing strategies. However, you really need an adherence of 6 to 7 pills per week, so 1 pill a day essentially, to have high levels of efficacy. And one question that comes up a lot is, how do I ask about adherence so that it's so that the patient doesn't feel like they're being judged, nor are they and also that you get objective responses. So these are 2 questions that I think, and I would suggest asking both. One is, how would you rate your ability to take your PrEP as it was prescribed, either over the past 7 days or 30 days? And you can pick whichever you want to ask, depending on whether you want a shorter term or longer term level of adherence. And the responses are written below, so from very poor to excellent. And the second question is, how many doses of your PrEP medication have you taken in the past 30 days? And the good thing with both these questions is that if the person says excellent, or I've taken every single pill, you know, ideally they've actually taken it. But if they say anything below excellent or 30 pills a day, it's a very clear sign that there is some non-adherence happening. And again, based on whether the person is a man who has sex with men, a woman, or someone who injects drugs, you can decide whether that's enough adherence or not. So improving adherence. These are some of the guidance that I took from the DHHS guidelines used for people living with HIV, and I just changed antiretroviral therapy to PrEP, but I think the same principles apply. So you really want access to trustworthy, non-judgmental, multidisciplinary teams. A combination approach is really important. So for people who inject drugs, that may not be the only risk that they have. And it's possible that some men who have sex with men also inject drugs, or individuals who engage in transactional sex. So it's really important really to understand what approaches are necessary to provide maximum harm reduction. And then you want to evaluate the patient's current PrEP knowledge. So understanding what their baseline knowledge is before providing additional information. And if everyone could put their computers on mute, I'd really appreciate it. So you can identify facilitators and barriers to PrEP adherence, and provide other resources besides PrEP. So any medication coverage, mental health, housing, food, transportation. You want to involve the patient in decision-making, and this is really important to decide what would work best for them. You want to ask about PrEP at each encounter, and identify reasons for low adherence, and maybe trying to brainstorm together some ways of targeting these barriers for the patient to overcome them. And finally, there's a slew of adherence tools, so things from apps to text messaging to activities of daily living, which I think is really important. So like essentially associating med taking with something that the person does on a daily basis, say brushing teeth at night, or you know, reading a book. Also there's pill monitors and pill boxes and alarms that people can choose from. So what it comes down to is that even though the body of knowledge for PrEP is not very extensive, PrEP use is only straightforward if all these conditions are met. So if the person's renal function is pretty steady, if they don't have any history of kidney disease or any other risk factors, if they have no osteoporosis or osteopenia, if their hepatitis B surface antigen is negative, given that both Truvada and Descovy can also treat hepatitis B, we want to make sure we're monitoring hepatitis B if the person is Hep B surface antigen positive. Also, for someone who can get labs every 3 months, as well as someone who's adherent. So there's a lot of conditions that must be met for someone to have smooth sailing. And most people probably don't fall into these categories. So there's a lot of nuance within the small body of knowledge. So speaking of side effects, I just wanted to go over the side effects of the medications really quickly. So there was a meta-analysis of 13 clinical trials that had looked at TDF versus FTC as PrEP. And essentially, what was noted was that TDF is very safe. And if you look at the various bar charts here, so the orange we have PrEP, which was TDF FTC here, versus the blue chart, which is the control group, there was basically no significant difference between the two groups, except when we got to creatinine elevations of grades 1 through 4. So when they combined all the kidney impact, PrEP with TDF FTC was a little higher than control. And I'm going to talk a little bit more about this in a second, but I first wanted to introduce tenofovir alafenamide, which is basically a cousin of TDF. And basically the difference is that TDF is metabolized into, so if you look at the figure at the bottom right, TDF is metabolized to tenofovir, TFV, in the plasma, and then it's transported into the lymphoid cells, whereas TAF remains pretty intact in the plasma, and then when it gets into the lymphoid cells, or the location of action, then it's metabolized to TFV and then tenofovir diphosphate. And that's really thought to be one of the reasons for fewer kidney and bone side effects. As far as efficacy for virologic suppression, they're equivalent, or it's non-inferior to TDF, and they both treat both HIV and hepatitis B. There is a thought that TAF may increase weight and as well as cholesterol compared to TDF. And we still need to monitor serum creatinine the same way we do for TDF. So this was the trial that basically resulted in the approval of TAF, which is called Discover. So they looked at 5,000 men who have sex with men and transgender women who have sex with men, and they compared TAF FTC versus TDF FTC. And as you can see in this graph here, the confidence interval for its efficacy, which was 0.19 to 1.15, crosses the relative risk of no difference, or 1, essentially. So basically meaning that TAF was non-inferior to TDF. So it was a little eyebrow raising because the FDA approval for it basically says that it's approved for sexual exposure, but not vaginal receptive sex. And that was a little strange because it also was not looked at for vaginal insertive sex either. So essentially, what we say now is that it's approved and has been looked at MSM as transgender women who have sex with men. However, we don't have data yet for any vaginal sex in general or for injection drug use. So there's really not a whole lot of difference in the side effects and safety between TDF FTC and TAF FTC. There's thought to be some less bone and kidney involvement with TAF, but none of this is really thought to be clinically significant. And also weight gain and increase in cholesterol is thought to be a little bit more for TAF versus TDF. And this is a kind of a busy slide, so I'm not going to go into details. I wanted to have all the information in place, but I also wanted to just talk really quickly about the PrEP startup syndrome, which is essentially that people do have some GI side effects, mainly nausea, gas, abdominal pain within the first 1 to 2 months. And this is about 10 to 20% of folks. And this is a common side effect and generally tends to go away with subsequent dosing. What I have noticed though within our the clinics that my project serves is that if someone is having a lot of the startup syndrome and it doesn't seem to go away and we've given it a good go, it is, interestingly enough, some people have done well with TAF FTC. So switching, which I didn't think would be beneficial, actually does have some benefits. So it's a thought to make the switch. And this is another slide that I really like because it very clearly demonstrates, so this is a study that was done in people living with HIV. It was about over 3,500 people in this study where they switched from TDF FTC to TAF FTC. And their kidney function was monitored over 18 months. And essentially what was noted that people who already had a baseline GFR, glomerular filtration rate, that was normal, so greater than or equal to 90, there's really no difference between TAF versus TDF. So TAF is in green, TDF is in yellow. So really no difference over the 18 months. Whereas people who had some reductions in GFR, so those who are 60 to 89, you start seeing a separation between TAF and TDF by 18 months. And realistically, those who were below 60, which I don't know why they were allowed to continue, but it essentially, that really showed a big difference between continuing TDF and worsening kidney function versus switching to TAF. So really, this just shows that baseline kidney function is really important to decide which regimen to use. And just a quick note on bone safety. So this was another part, there's a sub-study of the Discover trial. So looking at over 370 individuals. And there was a statistically significant difference in the spine on the left we have, and then hip on the right, with regard to use of TAF FTC, which is in green, versus TDF FTC, which is in gray. Again, no known clinically relevant difference between the two. So no increased fractures, for example, with use of TDF. And there was another study that looked at close to 400 MSM and transgender women, and they used 4,000 international units per day of vitamin D3. And they did notice that there was a reduction in bone turnover markers, or a blunting in the increase in bone turnover markers with use of vitamin D3. And I find that to be important, especially for patients who really have a concern around bone health, that there's a potential benefit with vitamin D supplementation. So it's kind of a blurry graph, but basically showing the weight changes. So this was on the right, Discover trial. Again, green we have TAF, gray is TDF. So there was a 1 kilogram difference by 48 weeks between the two. The investigators wanted to really show the point that maybe it's not TAF. So they looked at IPREX. So in the dotted line, we have placebo, gray is TDF, and really showing with TDF, there actually may be a weight loss or weight reduction. So there may be a combination of the two, a weight decrease with TDF and a weight increase with TAF. So we're probably going to see a lot more information around this to come. And I just love this slide that was created by Dr. Julia Marcus, comparing everything TAF versus everything TDF FTC, including the size of the pills. And really showing with TAF FTC, we don't have data for heterosexual and people who inject drugs, and comparing everything else around efficacy, safety, and cost. I added my little 2 cents at the bottom, which basically, I just wanted to point out that we have over 18 years of data now with treatment, and over 8 years of data for PrEP with TDF. For TAF, we have over 4 years of data for treatment and over 1 year of data with PrEP use, so for prevention. And the TDF FTC generic form has already been approved. It's not yet available, and it's thought to be, it was supposed to be available in 2020, but well, who knows how that's coming along with the current pandemic. But once that is available, there'll be a much lower cost associated with that. So that'll be a huge benefit. So how do you choose between the two? TDF FTC is a preferred regimen for all patients, and patients who are taking TDF FTC should just continue with it. If there's any renal disease at baseline, so if people have creatinine clearance 30 to 60, I would even go up to say 70 or 80 creatinine clearance. I would prefer to start with TAF FTC for MSM and transgender women. And also similar for bone disease, if people have any underlying osteoporosis or osteopenia or risk factors, probably TAF FTC is a better option if they're MSM and transgender women. For people who are requesting TAF, even though they don't have any contraindications to TDF, I would recommend TDF FTC. However, I just want to point out the importance again of the decision share making that we discussed before and empowering patients to really have the knowledge to decide. So we tend to go over all these details with the patient and make sure that they understand the risks and benefits. For patients who are requesting TAF FTC due to side effects of TDF, again, as I said before, we have seen some startling differences for these minor side effects, which I was not a believer, but people did well with TAF FTC, so an option to consider. And, and just to note that there's insufficient data to support TAF FTC for heterosexual men and women, transgender men, people who inject drugs, and also the 2-1-1 or on-demand dosing strategy that I will go into detail in 2 slides from now. And however, with all of that in mind, it's still a case-by-case basis that if someone actually really needs to be using TAF FTC, it's definitely an option to consider. And I will provide you with all the phone numbers for the PrEP line so you can speak to clinicians who are experts in this. So quickly about pill fatigue, we're going to see a lot more of this coming down the pipe, especially the injectables with HPT and 083. And this dosing strategy, which is called 2-1-1, is essentially based on the EPRGAY study, which showed that if someone took 2 pills of TDF FTC 2 to 4 hours before sex, then 1 pill 24 hours after and 48 hours after that, they had a high level of protection. And essentially, the main thing for this dosing strategy is that this was looked at MSM and transgender women. Again, if someone who's they needed to be Hep B surface antigen negative because TDF FTC does treat hepatitis B as well. So we don't want people to be going on and off TDF FTC. It's for people who generally have infrequent sex, and I don't know how to define that, but theoretically, if someone's having sex once a week for the entire month, they're probably better off just taking once a day because it's equivalent. If people don't wish to be taking daily meds, it's an option. We definitely want someone to be able to anticipate sex because they need to take the double doses at least 2 hours before sex. And the person does need to have some level of organization because of the single dose that's needed to be taken 24 hours and 48 hours after that. And again, we don't have data on heterosexual men and women, transgender men, and people who inject drugs. And I have some figures here, and I'm going to breeze through them really quickly, but essentially just to show if someone has multiple episodes of sex, we want them to continue taking single tablets up to 2 days after the last date that they had sex. And if there's fewer than 7 days between their sex episodes, they can just continue taking single tablets. They don't need to double up again. But if there's 7 or more days, then they do need to restart the double dose 2 to 24 hours before the sexual episode. And very quickly on HPT and 083, and I'm sure there's going to be tons of presentations coming out and already are out about this. Essentially, this was intramuscular cabotegravir injection that was given every 8 weeks. And it basically, the trial was halted because it showed that it was highly effective for HIV prevention among cisgender, MSM, and transgender women who have sex with men. So this was over 4,500 individuals. And among the 50 cases of HIV, 38 were in the TDF-FTC arm and 12 in the cabotegravir arm, basically showing that there were 3 times the number of incident HIV cases in the TDF-FTC arm versus cabotegravir. So we're going to be seeing this very soon. HPTN 084 is basically comparing the 2 medications in women, and we should be getting data from that pretty soon as well. Just in the interest of time, I'm going to skip through the Bangkok tenofovir study because I'm sure most of you are already familiar with this, but this was basically the randomized trial that resulted in the approval of TDF-FTC for people who inject drugs. And essentially, it showed that if people were at least over 97% adherent, there was about an 84% protection. And the risk factors, again, for poor adherence were men, younger individuals, those who were incarcerated, and also people who injected meth. And similar serious side effects between the 2 groups. Some of the barriers for PrEP use among people who inject drugs have been reported. They include low accurate PrEP knowledge, providers' lack of time and unwillingness to describe PrEP, provider stigma, and structural barriers such as poverty, homelessness, and incarceration. This is a really fantastic paper. I highly recommend if you get a chance to read it, but the authors went into detail about the various barriers, and they categorized them into individual barriers such as perceived risk, being different from actual risk, lack of knowledge about PrEP, competing priorities, and also heavy drug use. There were interpersonal barriers such as stigma, as well as medical mistrust. And finally, there were clinical or structural barriers such as complex PrEP protocols for the patients or the clinicians, transportation difficulties, and incarceration. And they came up with some suggestions for how to overcome these through interventions. So basically providing motivational interviewing so that patients can really be able to understand their risk. For example, behavioral capabilities and self-efficacy, which is basically like your actual ability or belief in your ability to be able to control your behavior, emotions, thoughts, and this was through brainstorming and problem solving. There was observational learning, so really asking peers and trusted individuals in the community to provide educational activities, and then really changing the environment, and that's where we all come in as far as culture competency trainings for this healthcare team, as well as changing any use of stigmatizing language that has been noted in healthcare field. So instead of talking about addict or a dependent person, talking about people who inject drugs or someone with a substance use disorder, and changing stigmatizing language. And really quickly, it's important to note that we also have PEP, and that's with 3 drugs, 2 of them being TDF and the other one FTC. It's given for 28 days, should be started as soon as possible after an exposure, and really after 72 hours, there's very little benefit. And these are the 2 phone numbers, which I will leave at the very end of the presentation for the National PEP line and PrEP line, where we have clinicians to answer questions about both. And this phenomena of PEP to PrEP switch. So we have a lot of folks who at the end of the 28-day course of PEP do have ongoing risk. So if their labs are normal at that time, we switch them seamlessly to PrEP by removing that 3rd drug. So either the valtegravir or the dolutegravir that was part of their PEP regimen. So really quickly, these are the 4 studies that are ongoing. So the PrEP-OI study, or the optimization intervention study, is a study that I'm the PI of. And essentially we have 4 amazing PrEP coordinators across the San Francisco Department of Public Health. And we have developed an online, a web-based tool for panel management that they use, and they can essentially impact the various components of the PrEP cascade to improve PrEP adherence and retention ultimately. So we are at 10 primary care sites. And essentially what the coordinator does, for example, in this schematic, they basically talk to the patient about their risk, medical insurance coverage. They do order all the labs. They teach about STI self-swabbing. Essentially write the prescription at the end and give it to the provider. And if they're okay with it, they can sign off on the prescription. And from then on, they basically follow up with the patient. They do all the adherence counseling and all the follow-up monitoring. If any side effects were to come up and if the patient were to have any clinical questions, they would route that to the provider. So really reserving the provider for when it's medically necessary. There's PrEP-Mate, which is our colleague Al Liu, Dr. Al Liu at the Department of Public Health, who has developed this based on the WellTel study in Kenya. So they send text messages to patients to ask them about PrEP. And essentially they've shown high levels of of adherence and retention. PrEP at home is really important, and this is something that I'm looking into more for DPH, as far as sending patients these home kits to test for all the various tests that need to be done for continuing PrEP. And finally, PrEP on the go. This is in Miami, basically providing PrEP care through this mobile van, which has been linked to increase in STI testing, HIV testing, and increase in PrEP use. So in conclusion, PrEP services should definitely be tailored for individuals. There's many people who inject drugs who are eligible for PrEP and should definitely be receiving education and support around this. Some of the various tools that can be used: PrEP coordination, panel management, telehealth, mobile health apps, the home-based testing kits to help with initiation, persistence, and decentralization. So I have a bunch of amazing PrEP resources here for you. On our site, prep.ucsf.edu, we have a bunch of resources for patients and providers, mostly also translated into Spanish and in Chinese. And I will leave you with that and the phone numbers for all the NCCC lines.
Great. Thank you so much, Padia. This is Carolyn again. First of all, I want to just thank you for that super jam-packed and very, very informational slide deck. And I know you spent a lot of time updating and sort of reworking it in response to some of the participants' pre-registration questions. So I don't know if you had your eye on the chat box, but we have a super engaged group today. I'm going to just go ahead and skip over to Stacy Noy's question, because I think a number of the participants did chime in on their thoughts to Jackie Tulsky's initial question around sort of time to PrEP effectiveness. So Stacy's question, I think, was around sort of the clinical decision-making between potentially choosing a TDF-based PrEP option versus TAF for women who are on depot, given the concerns around bone mineral density changes.
Wow, yeah, that's a really good question. You know, again, it's not been, the use of TDF hasn't been associated with clinical changes in fractures. So it's, you know, theoretically, as far as a clinical concern, it hasn't been shown to actually materialize in an additional risk. I do think, though, that that is a really important concern and deserving of further investigation, particularly with you know, any with aging that can also increase decrease bone mineral density.
Great, thanks. Stacy, was that helpful? Okay, and then we also see something in the chat box as well from our colleague Christina Gruda. You know, again, maybe a point of just counseling, bringing up in the patient encounter just to see if the patient might be open to other options for contraception.
Totally.
I will say that I think that certainly for pediatric providers, this question around bone health does come up, because I think that, there's sort of the data that we've got that has looked at for the first couple of years after PrEP has started, but then also long-term. And as you were saying, there's not really been anything meaningful as far as fracture risk, but we do know that these are established changes that have been, demonstrated in many of the TDF studies. And I guess the question is, what do you do about that?
Yeah, I mean, there's always the option of doing TAF-FTC. So I don't think it's necessarily wrong to do TAF-FTC. I think though there's there's an algorithm that will probably have in the coming years with additional options that will, we can follow, and probably it's kind of like the way we do with diabetes, for example. And TDF-FTC is probably going to be the baseline regimen, and then any differences from that is going to be on a case-by-case basis, depending on what we know about the patient that we're treating.
Great, thanks. And then I also wanted to just call attention to a ask that was posed by Elaine Nye, who looks like she's in Sacramento. So if anyone has easy access to some fact sheets around FTAF or Descovy use, she's got her email address there in the chat box if people don't mind sending them Elaine's way. And then also Brian and Baskel with our friends over the Pacific ATC, I think he included a link to some of the fact sheets that they've developed. Thanks, Brian.
Fantastic.
All right, are there any other questions that people want to throw into the chat box in our last couple of golden minutes?
I just wanted to just respond to Elaine real quick too. On the website that I posted, the prep.ucsf.edu, we do have some Descovy fact sheets on that as well. So if she does want to take a look at that site, there's some information on that.
Great. Well, thank you, everyone. I see some kudos rolling in for you, by a job very well done. Just to reiterate, a copy of the slides will be made available and sent out to all the registrants, I believe. If anyone's looking for more information about our group or what we do here at the NCCC, there's our information right there.
Thank you. This concludes our presentation for today. Everyone have a great day. Thank you so much.
Thank you so much.